In the middle of COVID, in the middle of craziness and chaos, with the middle of all of the data and the opinions and everything going on, it all comes down to a real core, a sickness that's affecting people. And today we are talking to Dr. Hubert Garcia, who is a hospitalist who specializes in internal medicine and is here in the Cleveland Clinic out in Traditions area. And we want to welcome you today to Revive Talk, sir.
Thank you.
With all of the information out there, with all that's going on in society, with all of the controversy over everything, I think probably for the most part, people don't really think about what's this like for a doctor.
Well, as a physician, I've been in practice as a hospitalist 5 years here in Martin County and Tradition. And before that, I was practicing primary care, and I was an internal medicine specialty, and for 19 years. And so it was a different, setting. You're from a clinic, now you're working full time in the hospital. So, of course, in the hospital setting, you're gonna be these are acutely ill people, and so it's more intense and more a lot of problems that you're gonna deal with. And like in a clinic practice, it's all mostly preventive treatment, chronic, diseases, hypertension, diabetes. So the hospital practice is definitely different. It changed dramatically with the pandemic, and you would think that we would be busier, but actually it slowed down because people were avoiding the hospitals, the ERs, and elective cases had to be canceled by the hospital. So there are no procedures, diagnostics and surgical procedures that have to be held. So it actually slowed down, but but the ER has also slowed down, but there's a lot of more cases of the what is possible COVID. So as a physician in the hospital, I'm in the front line. I work through the ER because I do the admissions there, and I take care of COVID patients myself. And when I admit these patients, so it is tough because you're gonna be very careful, extra careful. You can't get your guards down, and any patient who shows up, you don't know whether they have the COVID virus or not. So you could imagine how difficult it's for nurses and ER doctors, to just go and see a patient, not even knowing because you don't have the test yet at that very moment when they see the patients initially. So that goes through the lady that checks in that gets your initial vitals, the paramedics that bring these patients through their ambulance. So it is very scary.
So 6 months into a virus, as a doctor, what do you now know about the virus?
Well, there's still a lot to know about the virus. The first case was reported December 17 in the case of what they said was a pneumonia of undetermined cause in Wuhan, which is in the Hubei province in China. And it was first reported to the World Health Organization December 31st. And it was determined as a global emergency by January 29 or January 30. As a global, and then it was determined as a pandemic by March 20. The President Trump banned the travel in this January 31st, from China. But by the time, it has spread to Europe, and then of course, as you hear, that Italy was hit hard.
Yeah.
And then from Europe, then came to the U.S. because. So as far as the virus is concerned, there's still a lot to learn. They know the genome, which is it's an RNA virus. They know the sequence. That's why and the first time that China had the virus because they already isolated it. So they released the genetic sequence, I think in the middle of like January 12 or January 13. And so it's important to know the genetic sequence because that's how these vaccine companies make the vaccine, and to know, and the testing, So this particular virus is called SARS-CoV-2 virus. And the disease is called COVID-19. Okay, so it's a COVID-19 virus, but the disease is COVID-19. And the virus, there's the first SARS epidemic that happened, okay, in, I forgot what year it was, I think 2006 or 2007. And that epidemic was the SARS-CoV-1. Okay. That's the SARS epidemic that you remember.
Yes.
And so this is a SARS-CoV-2, and it's one of the family of coronaviruses. So how it behaves seems to be, different. And so, when you analyze the natural history or the natural course of an agent or a bacterial or virus, there's this how they attach, what do they attach to your body, to your system, and then how many days it incubates, and then the symptoms, and what are the organs that are going to be affected. So right now, they say that it's after an exposure, you got the virus, you can have a symptoms, start symptoms by day 5. And that's usually even just before that day 5 of symptoms that you already have a lot of viral, particles in your system. And you could even have passed that, as, you're being contagious. The 8th day to the 9th day of the illness is the peak, they say, the highest amount of, viral titers that's in your body. And so the progression of the disease, probably most of the people will have will do fine, benign, minor symptoms. Some of them are a good numbers, maybe asymptomatic, so you hear about having the asymptomatic cases. And then about 20% of them have a severe disease. And those people with severe disease end up in the hospital. And a certain amount of them really, die from the virus because of pneumonia complications. The worst part of the COVID-19 is the lung, injury, and this is an injury that's really that they say was triggered by the cytokine storm. It's just a bunch of stimulation of the immune system. And when you stimulate the immune system, it gathers all the cells, the macrophages, lymphocytes into that area. And unfortunately, it causes inflammation. And the inflammation that the body, reacts to causes the damage to the lungs. And you could see activation of the platelet system where you develop, microthrombi or, blood clots, clots. And they've shown that in the pathology of the lung from patients who died. So that's the natural course. Now, as far as anything else, there are things that we don't know. Like how contagious is the virus? How long after the disease? And they've shown that some patients still tested positive. And so, is this positive test mean they're contagious? So far they have not shown that. So then you wonder, why is he positive? Well, as I mentioned in the beginning, these are viruses are made up of RNA, DNA. Okay, so you have fragments of DNA, RNA in your secretions, just like when they do, investigative looking for a DNA for a crime scene. Yeah. They're trying to get remnants of DNA. So that's the virus can leave remnants of DNA fragments or RNA, and that can still show up as positive, but itself is not a viable particle. a virus is a structure where it's not just the RNA DNA floating around and going around. It's in a structure where it is what they call the nucleocapsid. It's with proteins on the surface, the spike proteins that you see, that they call the coronavirus, and then inside it is the RNA DNA. Depending on the virus, this is an RNA virus. So that's a viable virus. But if you just have an RNA DNA floating around, it doesn't mean that's a viable virus.
Okay.
And it can be detected by the tests, because that's what they do. It's a polymerase chain reaction test. They just, it's a test that uses those DNA, RNA, to test for the presence of the virus.
I've noticed conversation about the different kinds of tests, and I think there's an antigen test as well as an antibody test.
Yes.
Can you explain a little bit about the different testing?
Yeah, absolutely. There's two kinds of tests really, and the first test that is, I forgot what they say, it's basically the antigen and the RNA DNA test.
Okay.
That's one test, and then the other test is the antibody tests. Okay. So there's a lot of confusion there. Okay, just the general, I forget the term of it, but the general test is it specifically identifies the presence of the virus.
Okay.
Okay, and one is the DNA or RNA, and this is an RNA virus. So it detects the presence of RNA, and that's how you detect the presence of the virus. Or it's an antigen test. Antigen test means that the virus has proteins. I mentioned the spike proteins, the glycoproteins. In addition to that, the virus can produce proteins specific to the virus. So those are what we call antigenic, properties of the virus. They have these proteins that are linked to the virus. So that's what you test. Okay, so that's the antigen test, and then the RNA DNA test. The RNA DNA test, that's the reverse transcriptase polymerase chain reaction. That's the gold standard test, RT-PCR, that we will do a rapid testing in patients. When you do a swab, and that's what they're gonna run is the RT-PCR. And there are many companies that produce that. There's many, and then there's a few that are antigen tests. Now, the other group of the antigen and the RNA DNA testing, that's for the presence of the virus. So that's what is really clinically important, because that's what we want to know. A patient comes in sick. We want to know, does he have the virus or not? Okay. On the other hand, antibody testing is not really useful in an acute setting. It's not useful in the ER. We're not going to use it in the ER. We're going to use that for epidemiologic study. How many of the population possibly could have been exposed to the virus or are immune to the virus? And I think New York did that. They want to know how many people have had the virus. So they just do a mass testing, and you could see now what is the prevalence of the disease, how many people have the virus. And so that's how, the usefulness of the antibody test.
Well, you said something a while ago that really piqued my curiosity, that this is a second SARS. In other words, there was an original SARS back in 2006 or 7, and it was COVID-1, and so now this is COVID-2. Was there ever a vaccine for the first one?
Good question. I don't think there is a vaccine. One thing with vaccines, it is so difficult to produce, a vaccine. Just think about HIV. HIV has been out there years, 40 years, 30 years. Do we have a vaccine for HIV? The answer is no. And the reason is that it's for you to produce a vaccine, you have to form an antibody against the virus. Well, the virus is encapsulated in a capsid, so you can attack the surface, but you may not be able to destroy the center, the memory, the DNA structure of that. But the other thing is that viruses mutate. So the HIV is known to have, transformation that they could change their surface, okay, and one vaccine may work now during the research, and in a year or two, it's no longer working.
Which is why we have a flu shot every year.
That's why we have a flu shot, because there's different strains of flu viruses that form and develop. Yeah, so I don't think there is with the SARS one, as far as a vaccine to it.
And I don't think that seemed to hit the population as hard as this one. You said this is a very unique virus, and it's almost like a terrorist. It just comes in and operates. It seems to operate in different people differently, and
they could compare it. We can't really compare it to the SARS one because the SARS one only affected certain areas. Okay, and but you could, a lot of researchers and scientists would compare it to the flu. Okay, so because that's really what flu is like here every year, and so we deal with it. They say that the attack rate, when you have a flu and you're gonna be walking around, there's a chance that you're gonna infect 2 to 3 people. That's what they say. The figures 2 to 3 people with flu, and they think that that's about the same as the SARS-CoV-2, the coronavirus, COVID-19 virus. So if you think about it, it's gonna be the difference now is that flu has been here, and people have been exposed to flu, and people have been vaccinated. With SARS-CoV-2 or COVID-19, we don't have that. That's why they call it the novel. It's the new virus. So people have not been exposed and don't have antibodies, never been vaccinated. So even though that the same rate of may affect at a 2.5 scale of attack rate, secondary attack rate, you're gonna have more cases because people are not immune. There's no herd immunity.
Yeah.
And then, of course, the numbers, because people talk about numbers. Oh, there's a spike just because of the testing. Now, the testing means that people have it. When people have it, a percentage of that develop, as I said in the beginning, develop the illness. So when the testing goes up, cases goes up.
Sure.
ER gets busy.
Sure.
So it correlates. And so it's going to be, that's what you're going to see. And that's what, we've seen.
Well, while we're having fun talking, let's talk about masks. What's a doctor's perspective on masks?
I'm in the health field, and so you have a different perspective when you're in the medical field versus when you are not in the medical field. Now, being in the medical field, I'm in the front line. I see what's going on. I see the sickness, the seriousness of the disease, and people dying from the disease. If you have that perspective, you'll do everything you can to mitigate and control the spread of this virus. So, on the other hand, if you're a non-medical field, you won't see that. But, it is, so going back to the masks, you are the most important benefit of masks is really preventing the spread. If you're going to use it to protect yourself, well, it's really more on the preventing, because a lot of people walk out there, may have the virus, don't know about it. They sneeze, they cough, and stuff, and they spread it. People who are early in their disease already have so much virus in their secretions. Not aware about, it's just a simple cold, or it's just my allergies. Okay? So here, wearing a mask mitigates that spread of especially the droplets. And when you talk about, so controlling that. So they say that I mentioned earlier that it's difficult to do a study on how effective a mask is. Because again, you have to put somebody, if you're going to do a study, okay, you have a population, one, you're going to wear a mask, the other half, no mask, and you just expose them to the same environment and see who gets the virus and who doesn't. But you can't, you're not, that's not.
You can't put them in harm's way.
Yeah, it's unethical to do that to the people not to wear masks.
Yeah.
Okay, so you can't do that. But how they look at the data about this is by looking at the effect of implementing masks in a population or in a city. So like there are Washington, D.C. or a town in New York or whatever, they implemented it. So they looked at the cases, and this is an actual data. They looked at the cases before the mask implementation was enforced. Within 5 days of that implementation of the mask, they showed a 0.9% reduction in the cases, of new cases.
Less than 1%.
Less than 1%.
Okay.
In 3 weeks, 2% reduction. So a lot of people will say, hey, that's not really much, it's a small amount. But you talk about a pandemic where there is no treatment, there is no vaccines, and there's a risk of, people dying from it, that 2% will make a difference.
I totally respect,
Yes.
I honestly do,
Yes.
I totally respect your view as a doctor
Yes.
that anything we can do
Yes.
to reduce the spread of the virus is beneficial.
Yes.
Therefore, if masks somehow in any percentage reduce, then why not? And yet, that has to be measured against the cost
Yes.
of wearing that mask and what's going on in our society. I think that's an issue you speak regularly about what does it mean if we told everybody to go to separate bedrooms, close the door, and stay there for 14 days, we could probably eliminate a virus, but it's not practical.
Yes.
So now we have to figure out how do we not eliminate, but lower the curve, and where does that curve begin to be offset by what it's costing us to try to limit that curve? I think you've spoken quite a bit about what does it do for suicides? What does it do for mental health?
Right.
Yes.
I mean, there is that trade-off of just kind of in the conditioning that we're doing to people,
That's I believe that's a different because masks I don't think it has any effect on it. I think what you're referring to is the lockdown, the closing the businesses. Okay,
Right.
So those things. But for the mask itself, it's a simple thing. People make, in fact, now people make those cloth masks, and that's fine because it prevents the major droplet spray, droplet spray. So social distancing. So whatever whatever you could do, to mitigate or reduce the spread. So when it comes to the lockdowns and stuff, not opening the schools, not having the restaurants or whatever, and I think that's really it's a county by county, not even state by state. I think it's a county by county, city by city. So decisions and what are they doing? How are these businesses? Set standards that are just like OSHA requirements. You can't have this. You have a capacity to this room and stuff. So there's a lot of things that are already enforced by OSHA and the county. So I think it's theirs, and I agree. There's a lot of kids need to have to be out there. There's a lot of as you read about in the lower economic scales, kids that this is the school is their refuge. The school is where they get fed. The school is where they get diagnosed with abuse and trauma and stuff. So you're depriving them of those. So yes, there's a lot of things. As far as the economic impact, we know it's really hit the economy so hard. And we could we have done something differently? Probably, but again, this is an unusual, just situation. I wish we just gonna go through this once in our lifetime, never again.
I pray so. So many unknowns. I mean, keep everyone inside, no playgrounds, no beach, no fresh air.
Yes.
Wear the mask inside, wear the mask outside.
Yes.
Just the reality. And then, some of like what stores remain open and don't. Walmart gets to stay
Yes.
open, and then Steinmeier has to go out of business. It,
Yes.
You know,
It's a difficult time, and honestly, you know, the trying to weigh reducing the curve or in some way getting near eliminating a virus brings out so many different issues to deal with it.
Yes.
Like the distancing, like the shutting down, like which doesn't do really anything more than bring about a bunch of controversy and a lot of things to talk about. And I think every coffee shop and every restaurant and every home in America has this at the top of the agenda because there's just so much to talk about when it comes to try to figure this thing out. For you, being a doctor, I want to say thank you. You are going into an environment every day that you go to work, every day knowing that virus is there, and knowing that you have to protect yourself and yet treat people who are dealing with the virus itself. So I want to start by saying thank you. Thank you for being a doctor in our local community. Thank you for being a friend of ours. Thank you for taking the risk of going to work every day to help other people. I think it's admirable. I honor you for that. I appreciate you for that. And I pray for you because I know that you have a tough task at hand in dealing with this thing on the very front line.
Yes.
Our guest today has been Dr. Hubert Garcia with the Cleveland Clinic here in town, who has spoken of his own opinions and his own thoughts, not necessarily representing Cleveland. But I thank you so much for the information. I mean, just understanding how virus medications and things are put together so we can understand how this process is, what some of the terms being used in the media are, so we have a better understanding of what we're dealing with and how to walk through it. Thank you for coming and talking to us today. It's been a great benefit to us.
Yeah, my pleasure.
And I want to thank you so much for joining us today on Revive Talk with Dr. Hubert Garcia. God bless you. And as we walk through this thing, believers, let's just continue to pray that this thing gets eradicated from the planet and we can get on with our life. God bless you. Have a good day.